And I'd like to introduce our next speaker in the session, Brian Wang. He'll talk about machine quality assurance and patient-specific QA.
Thank you, Jane. So the way we lay out this session is hopefully Stan use some of those incidents scare you enough, and then Jane lay out a process and the workflow you need to follow, and then now I'll come to some machine and patient-specific QA, and then next Dr. Burmester is going to talk about practical considerations for SBRTs. So I have no disclosure, but some vendor names definitely get mentioned here, and then don't feel you got biased either mentioned or not mentioned in the slides. And so this is my outline. It's hard to talk about machine QA without mentioning TG142. And then specific for SRS and SBRTs, I'm going to talk about the Winston lot and the image guidance, and also end-to-end test. And I'm going to quickly review some QA tests for common SRS and SBRT platform or machines. And then lastly, I'm going to touch base on the patient-specific QA, especially from our experience on the motion management front. So I guess people live in this room already be very familiar with the TG142, and I just want to bring it up here. This is SRS and SBRT education school. So let's look at what is different for SRS. So on this first slide, and you can see on the daily QA here, and then there's 3 columns in TG142. The first is non-MRT and the second is MRT. But I want you to focus on the last column. That's the SRS and SBRT machines. And then as you see, anytime there's an empty space, that means the parameters are same for non-SBRT machines. So look at the far right column and see the empty space. It's on the daily, there's some difference here. I'm going to summarize. And then on the monthly, I don't expect you to read the detailed numbers, but you can see there's quite a bit of white empty space here, which means the non and the SBRT machine and the SBRT machine have same values, all those empty space. And if you further go down to the annual QA, we would really need a magnifying glass to read this. But you can see still there's a white space here. So I come into a summary. I went to the table and look at those and what's the major difference and the similar things. So basically, all the difference for this daily, monthly, annual are for mechanical tests. And there's a non-difference on the safety or dosimetry test. And for those tests, and then I summarized into this table, and for daily, monthly, and annual, and then you can see for the S on the far right, it's for the SRS machines, and then on the next is left is non-SRS machines. And I remember about maybe when I first get into the field, of course, when you talk about machine QA, you still talk about TG40. And I remember one mentor once told me about this. If you blank when you do your oral exam and then you blank on the numbers, just tell them 2 mm, 2%. 2 is a magic number for us. And I think right now I just want to show you here, and then maybe now if you want to, if you blank on any numbers when for SRS and SBRT for oral exam, whatever, just say 1, and most likely you will be right. So, and then again, so I don't expect you to read this, but here, the message here is on this table for TG142, for the table 6 of imaging, you can see here, there's not many empty space anymore. That means all these imagings are pretty much, the numbers or values are different between SRS machine and the non-SRS machines. So to summarize, again, So basically for all daily, monthly, annual procedures, the function test and the image quality of those, imaging those tests, are the same between SRS and non machines. And for almost all other tests, almost, not 100%, but it's pretty much a millimeter for SRS machine and a 2 millimeter. So still 1, 2, so. There's, of course, some exceptions on the TG142 on those table for the imaging test. So next, I'm going to talk briefly about the Winston lots and the image guidance and end-to-end test. So as Stan mentioned this reference already, and then so the quality and safety consideration in SRS and SBRT, and it recommend Winston lots type test should be performed daily. This is about QA frequencies. And then also the QA of the image guidance should be performed daily if you use it. Of course, if for example, for gum knife, if you currently don't use image guidance, it's not applied here. But nowadays, most of the SRS and the SBRT procedures, we use image guidance, and you need to do those daily. And as Stan mentioned earlier, and also Jim mentioned, end-to-end test, I recommend it both at the initial of commission and annually. That's a QA frequencies for this specific task for SRS machines. So a Winston lots test, just a quick review. It's basically, it's a test of the radiation isocenter and versus the mechanical isocenters for different gantry, collimator, and couch combinations. And you take multiple shots at different couch and gantry angles, and then you use target inside hidden target inside the pool, and then you get these images. And also in terms of what gantry and the couch angles you design your own Winston lots test, it really depends on your own program. So if you do couch kicks for your planning, then you need to test with couch kicks. But if you only do co-planar arcs, maybe you don't have to test the couch kicks for your test. So again, from this this reference, it mentioned the recommendation is for a Winston lots test, the maximum is 1 millimeter, and the average is 0.75 millimeter. The average here is basically if you have 10 different shots or 4 different shots, then you average them out, but then individually you have the maximum of 1 millimeter. Also, I don't have that mascot here to be a reminder, but my SAM question is going to be at the end, and all my SAM questions is about values and numbers. Next is come to image guidance QA. So so early days, Novellus it's one of the early machines doing SRS. And then, so for image guidance for Novellus ExactTrack system, you have this test for the ExactTrack system, and then it give you the numbers every morning. You test this, and quick procedure. It takes about a minute. And then also on the TrueBeam platform, and then you can have all these different phantoms. And then typically on the morning, therapists have this cube, and then align your CBCT or orthogonal pore films, and then look at those shifts. And then so next, I want to talk about the end-to-end test. As Jim and Stan mentioned already, ARAC Houston have this end-to-end phantoms for you to test if you are participating protocols. But even you are not participating protocols, actually they are very reasonable price. You can call them, and then I think they can have that set up, and then a couple $100, and then they can send you a phantom to do this. That's the good thing about that approach is basically your program is really audited or verified by an independent organization. So they give you isodose distributions and also absolute dose distribution. Here, I'm going to get into some of the more of in-house. What kind of phantom? Actually, everybody, we have solid waters, everybody. And then you can design your own phantom to do some specific aspects of the end-to-end test for the purpose you want to verify. The good thing about this is instead of paying the couple $100, that's not a big deal, but mainly you have to get into the line and wait for the result. For this, you really can design it, and then you test it, and then you get the result on the same day. If there's anything you find you need to fine tune, you can always went back and forth, and then to trying to figure out where is the difference. So this process, I just want to give you an example. So basically, you get a phantom and then get a hidden target inside the phantom. In this example, I have a random head and then put a couple of tungsten balls inside the head, and then make a mask for the phantom, and then just CT scan, put localizer, everything like you are doing for a patient. And then so you assimilate the whole process over this, and then next is basically you for course for frameless SS, you need to make a mask, and then you have all this, and then once you scan this, you transfer all the image into a planning system, and then since you have the hidden target, you can identify that, you contour, you place your isocenter on there. And then on the machines, and then you go to expose the film. Of course, for the frame-based SRS, nowadays not many people are doing that anymore, but you repeat the same process, and then you put your localizers. But of course, for frame-based SRS, typically you don't use image guidance, and then you print out a template, and then you align on the lasers, and then to the templates, and then you from there you attach a cone to the linear accelerator head, and then you do a couple shots, and then, so the process over here, what I described in my end-to-end test, is more of testing the spatial accuracy, not much on the dose accuracy. So I have a separate process. If you want to do a dose verification, and then you design your own phantom, you put a solid water steps, and then you scan those, and then use some film and other tech. So next, I'm going to mainly go over some QA tests for some common SRS and SBRT machine and platforms. And then most of these slides, some of them I have it from my own institution. I worked with them before, but some machine I never worked with before, so I borrowed some slides from my colleagues. And so machines I go over here, and it's Novalis, TrueBeam, Electa, Vero, and Subknife. So for Novalis Winston Lutz test, and then so those data over about 4 years of data of Winston Lutz, I have an average of 0.6 millimeters, and then also in literature have couch only or gantry only, and if you look at the 3D vector, is about 0.35 millimeters. Here it's about 0.4 millimeters. So here, the purpose of my slides here is not to talk about the details of how you do it. It's more about what others, the data comes out. And then, so those are for the Novalis Winston Lutz test. And also, I did all this Novalis end-to-end test, and then for a frame-based early years, we've done lots of those procedures, and then now for those Novalis, the frame-based is mainly used on trigeminal cases, and then for most other reduced surgery procedures use a frameless. And you can see with all this, in pretty much all sub-millimeter, and the 3D vector is about 0.9 millimeters. That's numbers over the years we have after several of those. And on the true beam Winston Lutz test, and I borrowed this slice from Winston. I borrowed the Winston Lutz test from Winston, and at Henry Ford yesterday, you saw their edge machine, and then their machines are very, very tight, and the most of the maximum is you see here. You may have one point is like a millimeter. Most of the even the maximum is about 0.8 millimeters, and then the average is really tight. It's about 0.2 millimeters. And also based on my own experience, really, the machines, at the beginning when you commission the machines, typically these numbers, you work with the install engineer and you can get it really tight. For example, on this case, 0.2 or 0.3 millimeters. But actually, as time goes on, I haven't talked to Winston Wang yet how their machine after a year behaves. But my experience is like after a year or two, and then those numbers will start to creeping up a little bit. And then they usually, like for example, my experience with the Novalis, they will go creep up with 0.7 millimeter also. At that time, sometime you get the engineer back and then try to tie it up, and then it doesn't matter how you work on those, and then so it's still very hard to bring them down to the initial like 0.2 or 0.3 millimeters. So, and then you saw these slides already. So they did they did a lot of end-to-end tests from different combinations of gantry, rotation, and collimators, everything. And basically, the take-home message here is most of these numbers, maximum is less than a millimeter, and the mean is about 0.4, 0.5 millimeters on this true beam edge platform. And have this slice from Dr. Sam Hancock, and then on the electron machines, actually all these electron machines, I think all these 4 machines, 2 of them from him, and then the other 2 are from University of Iowa. And for electron machines, they did a lot of tests, and then they separate the gantry arm flex and also the table axis separate out. And then from, as you can see here, is you get down to 0.6 or 0.5 millimeters. And actually, he has another detailed slice I saw is basically before he worked on with the engineer on this, and so some numbers actually from certain angle is 0.2 millimeters or 0.3 millimeters. But then from some couch angle or gantry angle combination, and then you have maybe 1.1 millimeters. So what he worked with the electrics and others use to really to tighten up the machine, so make a compromise. So he doesn't have a 0.1 millimeter anymore from any single gantry angle, but he doesn't have more than 1 millimeter tolerance either. So he pretty much bring down and average out, and then this is how he settled down with 0.6, 0.5 millimeters on the gantry arm. And he said it's basically, as you can see, the limiting factor is in the gantry arm here, and the table axis rotation are very tight. It's only about 0.2 millimeters. So on the Vero machine, and then they have this TOEFL Phantom, and then of course on the TOEFL Phantom you have this imaging QA, KV ISO, and the NV ISOs, and then also you have the Vero machine have a ring structure, and then you test the different ring angle with a gantry angle with Winston Lutz test, and then from Dr. Su's experience, they are about less than 0.2 millimeter variation. And like I said earlier, it's really how you pick up this ring angle, gantry angle, or couch angle. It really depends on your plan, how you design your own Winston Lutz test. And Subknife, as some of you users may know, Subknife have its own end-to-end test Phantom. And also it has an AQA phantom. I consider the AQA phantom is like the Winston Lust test for every morning. AQA test you perform every day, and then the end-to-end test you perform a couple times a month. And then because some knife have different collimators, have RS, have a fixed cone, so you want to test those in different on different days. And then this is the data we have from University of Louisville, our AQA number. You see here, a couple of them is about millimeter, but majority of them and the average probably about 0.6 millimeters or so. And the end-to-end test is similarly, this is over about 3 years of time, and the majority of them is about 0.6. Every time you feel like it's creeping up, and then you call the engineer come back, tidy up, and it's come down a little bit, and then after couple months, and it went up a little bit. So watch out these numbers. The next section I want to talk about is patient-specific QA and MRT QA. There's a lot of debate on measurement or calculation, and also from yesterday, the vendor talks, there's several of them. I talk about use different tools to verify with the calculation. So I'm not going to get into this hot topic, and you can read some of this and have your own opinion what to do on. But I want to mainly talk about here is, as I mentioned, for all these QAs, just use the TG100 philosophy. Basically, look at what process in your own program are weak, or you are doing more. So you do more QA in that perspective. So in terms of commission and ongoing QA. So for example, in our program, we does a lot of motion management, and we do quite a bit of breath hold and gating for lung and liver SBRTs. So because of that, and then we got we need to test more on this motion management. And then of course from TG142 it says you basically need to test this temporal accuracy, and also you need to calibrate a circuit for the phase and amplitude. And also TG142 recommend you use a dynamic phantom to test the whole process. And in our particular example, we have the Delta 4 Phantom, and then we were lucky to work with the early version of the motion platform from Delta 4. It's called Hex Motion. So we use this Hex Motion. It can move the Phantom in three-dimensional. It can do shifts and rotations. So what we did is end-to-end test, and we have a healthy volunteer lying on the CT couch. We get the RPM signals of different breathing patterns, and then we put those breathing curves into this Phantom, drive the Phantom to go to different, and then of course we develop a CT scan the Phantom with this breathing curve, and then we plan on it, and then we put a breath hold, and then we go to the machine, deliver just like a patient treatment. So that's the test result, and we have, like I said earlier, the health volunteer have different breathing forms and different ways, and then we come up with those data. That's how when we commission the process, and then this paper just accepted last week in JSMP, and you can look it up for it. And then ongoingly, of course, when we do patient treatment, and then we also use the same process with patient-specific curves put into the Phantom, and then to do this QA. So my point here is it's not encourage you to buy any particular Phantoms, but really if you do a lot of motion management in your program, and then get some kind of dynamic Phantoms, and then do an end-to-end test, and then the first test out the workflow. Second is really try to see what's the gamma pass rate on this. So my first SAM question is, which of the following category in TG142 has different tolerance between MRT machine non-SRS machine and SRS machine for daily, monthly, and annual test. So the first is safety, dosimetry, mechanical, respiratory gating. Okay, mechanical. I lied a little bit here. I said all my SAM questions about the numbers. This is not. But then I guarantee you the next two are all numbers. So yeah, it's mechanical, and all the other tests are the same, actually. Again, for TG142, what are the tolerance for the majority of the 2D and 3D imaging test? Remember, this is the table 6 on the imaging test. It's not many black space, that table. What the majority tolerance for the SRS and SBRT machines? Great. Physics like numbers. Whenever we have numbers, it's very difficult for majority of the physicists to fail any of those questions. So my last SAM question, what is the tolerance of Winston last test for SRS and SBRT machines? So number 1, 0.5 millimeter of average. And number 2, 0.75 millimeter on average. And number 3 is 1 millimeter on average. And 4 is 0.5 millimeter max. And number 5 is 1.5 millimeter max. We have a little confusing there, but it's basically the recommendation from this reference being talked about today a couple of times is the recommendation of Winston is 0.75 on average and 1.0 maximum. That means each individual you want to keep it to less than 1, and then on average 0.75. That concludes my talk, and like I said, many of my team members contribute to these slides, and also I have several colleagues share their slides with me.